How are you? Can you hear me?
Good, how are you?
Good.
I know you've been having such a busy day. I really want to take a minute to just say thank you for doing this with me. It means a lot to me that, you're taking the time out and just talking to me about something that you and me, we both love so dearly. And it's something that's so close to our hearts. So thank you so much.
Oh, absolutely. I mean, the partnership with physical therapy and orthopedics are incredibly important.
Yeah.
So no, it's a pleasure.
Yeah.
Thank you.
Oh, yeah, I love talking to orthopedic surgeons because even I specialize in musculoskeletal and sports physical therapy. So I love speaking whenever I get a chance. I love picking their brains. Whenever I get a chance, I love assisting them with their corticosteroid injections and just
Oh, wow.
yeah, I love those. I love it when the injection is not given to me, but I have to like witness someone else getting it.
There you go.
Okay, let's dive in. What, according to you, is the definition of health and fitness?
Oh, that's a great question. Health, health and fitness. I think go hand in hand. There's different. First of all, there's different ways to look at fitness and health from an orthopedic standpoint. Our
Right.
perspective is biomechanical and anatomical, and the thing that comes to my mind is postural fitness. When you focus on postural fitness, the health benefits are secondary. They come along with that. I don't know if you're aware of this, but with good posture, your inflammatory mediators go down. They've taken blood levels, I think, in some of the institutions in New York, and found that the markers for inflammation have gone down when your posture is improved, right? And your alignment is improved, and you have proper body mechanics. From an orthopedic standpoint, posture also means that the length tension relationships, as you know, of your muscles are at the correct level. So often in our day and age, being in front of the computer, sitting down a lot, we're kind of misaligned, and we have to remind our body or cue our body to realign, and that's very difficult. Sometimes we have to go to the therapist to do that. So for example, when we're sitting down for long periods of time, our gluteus, our posterior chain, and our hips are stretched out, and our rectus is shortened, and so our pelvic is anterior. And that sets up a lot of problems for a lot of people that you and I see in our clinics. Hamstring tears, things like that, because they're not balanced correctly in the beginning. So from an orthopedic standpoint, in particular, posture is really, really important, and that's just one example. We could look at the scapulas and how they drive the not only the shoulder articulations and keeping them in line so that the rotator cuff is firing correctly, but also what happens, there's a chain reaction when the shoulders are in proper alignment through the scapula. The cervical spine, thoracic spine, and lumbar spine follow. Very interesting kinematics. So everything's connected to everything else. And, when we have good posture, we're going to have more energy. We're going to have better blood flow to our extremities. Studies have shown that. And we're going to have less inflammation systemically. So postural fitness drives that, and it's fascinating. But that is the connection to health. That's how I see it. Now, I also see it through a lens that's very focused because I do a lot of shoulder and knee surgeries. So when people aren't training correctly, when they're out of balance, when they're not doing things you know, with correct posture and correct form, and
Right.
their muscles aren't in synchrony, where they can co-contract across the knee, for example, that's when you can tear the ACL. That's where you can tear menisci. That's where you can get cartilage lesions, and you could get, you know, synovitis and further breakdown of the knee. And, you know, the same holds true with the shoulder. You know, in younger patients, you can dislocate. You can spontaneously, you know, dislocate and relocate and
Right.
tear your labrum, get biceps problems, undersurface rotator cuff tears. So, in short, when we're in good alignment, when we fire our muscles efficiently and we can co-contract across those articulations, and in my field, you know, the important ones for me
Yeah.
is the knee and shoulder, we're at less risk for injury as well. So that's kind of my kind of 60,000 feet perspective.
I love that, because I'll tell you, we have seen you're so precise with it. I have seen cases where the toe, in-toeing, out-toeing case, just toes. They come with feet pain, maybe plantar fasciitis, some ankle, instability. It's found out that the root cause is all the way up in the shoulders or in the cervical. Because of
Yes.
this posture, their cervical is bending, their lumbar is bending, the hips are tilting, their knees are going valgum, and then ankle is being unstable because the knees are unstable. The root cause is all the way up.
You're 100% correct. And what's the beginning of the end? You know, you see the person like this, and then you go like this, and then as you get older, you're like this, and then you get that kyphosis.
Yeah.
It starts off as a flexible disorder, but when you get older, and that flexibility,
Yeah.
because of the overpowering of the pecs against the weaker back muscles, right? That imbalance eventually becomes a fixed deformity when the discs start ossifying in that position,
Yeah.
and you can't correct it anymore. It becomes too late. And then what happens to the elderly? Well, they're not looking straight ahead when they're walking anymore. They're looking down on the floor. And
Yeah.
that's the beginning of the end, because when they fall, they get the hip fractures. When they get hip fractures, the mortality is like, you know, some hip fractures, mortality within six months is 75%.
Yeah.
So these are things that are preventable, that can really make a big difference. And you know, when we think about posture, now we want to think about, you know, later on, because right now we can correct it, but when we're older we can't correct it because it becomes a fixed deformity. All deformities start off as flexible, but then they eventually, if you allow it to continue, will become fixed.
Yeah. Plus, with age, there's so much cartilage loss, there's so much wear and tear that they're just, like you said, it's just fixed. It's not, there's not enough fluid, synovial fluid, there's not enough joint mobility. It's just fixed. There's porosis, there's arthritis, there's so many factors that are causing pain, and it just comes down to proper posture.
I agree.
Yeah.
I agree. And we need the therapists to help us get our balance back. You know, it's really important.
Yeah. That makes me bring to the next question. You work so closely with the therapist. Like, physical therapy is, I would say, it's not super new, but it's still such a new field, and there's so many evolutions going on. We're still in the trial and error phase of physical therapy. We're trying so many things. I'm so glad that orthopedics and PT they work so closely. How important do you think prehab, or rehab before the surgery, is to a patient?
Very important. Most of my patients have had therapy before surgery, unless it's a full thickness rotator cuff tear.
Mm-hmm.
But even in those instances, if they start getting a capsular pattern and starting to get adhesive capsulitis or a frozen shoulder, we'd want to get their range, you know, free up that axillary pouch. so that when we take him to surgery, we're not worried about adhesions, because that's one of the complications of rotator cuff surgery. ACL surgery, definitely literature has shown that doing therapy before doing the ACL is really important, because they have a quadriceps avoidance gait. The quad shuts down, and so we got to reestablish those neural patterns to get those very important muscles, so important for the post-op success. Also, getting full range of motion after an ACL, getting the swelling down, is really important. So doing prehab or pre-surgical rehabilitation is critical to getting good outcomes, in my opinion.
Yeah, definitely. I've been seeing so many patients now with pre-surgery and post-surgery. When they come back to me, I've seen amazing results, where a normal person should take 3 to 4 months, 3 to 6 months of rehab. These patients are getting up and moving around and getting back 100% range of motion in what, 2 months, 3 months. And it's only because of like the movement. So movement is the new therapy. What do you think about motion or movement being, movement therapy is coming up? What do you think about movement therapy?
I think it's really important. That, I mean, you talk about movement. The joints are meant to move, right? I mean, and you get your nutrition from that movement. The synovial fluid gets into the cartilage cells through joint motion. Joints are meant to be moved. They're not meant to be immobilized at all. So, and that in orthopedics, that goes with why we operate on intra-articular fractures, so that we can move them early. So yeah, everything fits what we know in our literature and what you're telling me.
Coming to posture, what are a few cases that you have seen or you come across day to day?
Well, I just had a case today, very interesting case, of a patient. He was, I want to say, in his early 30s. He had a labrum tear. He tore the cartilage in his shoulder, and he had bicipital tendonitis, and he had about 3 months of therapy, and his pain was an 8 or 9 out of was not getting better. And he did 3 months of therapy. It didn't get better. And so I knew of a device that is an FDA device that I use in my patients. And I suggested to him, I said, listen, we're probably going to do surgery on you. You're not getting better. He had exquisite biceps tenderness. And he did have an apprehension sign, significant apprehension sign and relocation sign, meaning that the labrum, the shoulder was sliding out in the provocative positions. So, he wasn't looking like he was going to do well with conservative management. So we're going to give him another 4 weeks of basically, I told him there's a posture shirt out there, the Alignmed posture shirt, company in California that makes this. It's an FDA device, and it's been well studied. There's been a lot of literature out there. It's actually used in every Major League Baseball team because of the benefits that improve blood flow to the upper extremities, the ability to bring the glenohumeral joint back 1 to 2 millimeters through all range of motion. This was done in a kinematic study, biplanar fluoroscopy study out of Philip Hawkins in Vail, Colorado. That fact, and the fact that it can position the glenohumeral joint in very advantageous positions from a shoulder surgeon standpoint is really important. So he wore this thing for a month, and I saw him today after he wore the shirt, the Alignment shirt, for a month. And he told me his pain was completely gone, and that he was at his pre-injury state. I was shocked because today was the day we were going to mark his surgery. We are going to schedule his surgery. And he's like, you know what? I have no pain. I took him through through all the range of motion. I put him in, the position for apprehension. He had no biceps pain, which is unbelievable because you know how hard it is. Once they get biceps tendonitis, it's almost impossible to get rid of that. This shirt got him, and it is unconscious therapy. It basically cues the scapula to be in the correct position, and it opens up the articulation and pulls the glenohumeral joint back 1 to 2 millimeters. And, that doesn't affect the labrum anymore because the shoulder is posterior. It's not sliding out. So I've had a couple case reports of myself with patients that had dislocated, and I treated them with the shirt, and then I went in to scope them, and the labrum was completely healed, which was unbelievable. But it's based on that data from Steadman Philippon in Vail, Colorado, that the humeral head will go back 1 to 2 millimeters when you're wearing the shirt, which is amazing. And it goes to show what you guys do when you're cueing the scapula with your tape and with your exercises. What the impact that has on the glenohumeral joint is profound.
Right.
From a pre-injury state and in a post-rehab state.
Definitely. But my question is like, because there's so much tightness in the pecs, and like you said, there's always that, in spite of taping, it's always going to come back to the rounded shoulders.
Yes.
With this device that you mentioned, does it cause a lot of pain while pulling this and actually keeping it in that position? Does it cause pain or soreness with the patients, given the back muscles?
No, actually, it gives them a workout. In the beginning, so it's unconscious therapy. It's not like rubber bands. This is actually making your muscles work. I mean, so it's having you with them 24 hours. They only get you 1 hour. Then they go home, and then it's like, what do we do? This device actually cues them while they're not with you. They need you. They need the postural education, but then they get the unconscious therapy. But yeah, there is a break-in period where you do have some soreness in the beginning. So you can't, some people that aren't in shape, that aren't athletes, may want to wear this, a couple hours and then build themselves up, because it's not like, but then they do feel better. One of the worst things for us is pec minor, right? Because it presses on the brachial artery. And, there's studies to show the blood flow. There was a study done at University of Southern California with this shirt, and it showed that the blood flow distally improved 3.3%. This was Department of Vascular Surgery at University of Southern California. This was published at the American Academy of Orthopedic Surgeons, and it was because you're stretching out pec minor, which is the big offender of your blood flow to your arms. But you're right. You got, if someone who's not in shape, they should wear it for a couple hours and then gradually, it's like, someone who's not in shape and they're doing therapy, can you imagine them doing therapy like 24/7? They're gonna get tired, right? So, but an athlete, you could wear this. I wear this thing when I sleep. I mean, it's great. I wear it in the operating room, and I wear it in clinic, so it helps out.
Does it not, like, because there's, like you mentioned, there's weakness in the upper cervical, the scapular muscles. Wearing it so constantly, wouldn't it stretch out the pecs more?
I don't think you stretch them out enough, because the imbalance. It's almost unfair. It's like David versus Goliath. I don't think you can stretch these guys enough. You and I both know the end game, right? From the pec imbalance, right? The end game is this. It's just incredible. And when we see, our older patients, hunched over, it starts from the pec. It's horrible.
What's the difference between the devices that we already have, the belt and hook ones, than the device that you're mentioning? What's the difference?
The difference difference is this is active. You know the concept. Obviously, you know the concept of kinesiotape. This is kinesiotape activating that posterior chain. In the front, there's nothing. It's not a compression device, even though it's form fitting. It's not a compression device. It actually is loose in the front to accommodate bellies and to not be compression. Why? Because muscles don't like compression.
Yeah.
They did a study at Curl and Job looking at this versus Under Armour and someone without a shirt. And they did Biodex external rotation, peak torques. And guess what? This outperformed all of them by 15%. There's a 15% increase versus the controls with peak torque external rotation for the rotator cuff. The person without the shirt outperformed the Under Armour compression shirt. And Dr. Elatrash, the author of this, very famous doctor. He's a doctor for the Lakers and the Dodgers. You know, he's like doctor of the stars over there in LA. He said the reason was muscles don't like to be squeezed. It's like a tourniquet. So this whole thing about compression is actually wrong. So this doesn't compress. It's form-fitting, but it's loose in the front so that it can accommodate belly, you know, people that aren't, you know, fit, you know, because a lot of people who aren't fit need to be able to put this shirt on. That's why they have a zipper, you know, a zipper version of this as well.
So is it the tape working on the back,
Yeah.
on the weak muscles, basically?
Correct.
I see.
Yes, that's exactly right. And use the scapula to, as you know, to get in the correct anatomic position. And then when that happens, then the chain reaction of the cervical spine, thoracic spine, and lumbar spine follow.
Mm-hmm. Plus, it's contact with the body, so the tactile sensation is also activating, which in turn.
Touch tension activation. Absolutely. You're very familiar with that.
Yeah.
I mean, you're dealing with touch. I mean, in your profession, you're hands-on. If you're not using your hands and if you're not tired at the end of your day, you're not doing therapy, correct?
Correct.
I mean, that's the patients feel that. They need that. They need that. You know, the touching the skin is so important.
Yeah,
so important.
Definitely. Most of our pain sensations are on the skin.
Yes. Yes.
The basic concept of TENS machine or electrical stimulation machine is just the skin contact.
Correct.
Yeah. Have you come across any patients with like postural instability on their hip or down below, like with their knees, etc.?
Yes, that's a very important point. So, you know, it starts up here, but then you have to connect at the hips, right? The hips are so important, and you know, we're sitting down all the time. You know, except for you and me, we're always standing, right? But most of our patients are sitting down. I mean, we have to think about that. I mean, I'm standing in the operating room. I'm in clinic. I'm going, you know, from room to room. So I'm usually standing. I like to stand. But you know, when they're sitting, again, the imbalance is the same thing. It's the strong rectus femoris in the front, you know, with that short rectus, right? And the pelvis, what happens to the pelvis? It goes anterior. You get anterior tilt of the pelvis. And then your glutes in the back, your posterior chain, just kind of disappears, elongates, and that's why we get hamstring pulls all the time, because we got that short rectus, and then you elongated and weak posterior chain, and you know your patients, my patients, they're sitting down at a desk 5 days a week, and then they're weekend warriors, and they guess what? They pull their hamstring. Shocker.
Yep.
You know.
As soon as they come in, I'm like, you got to, number one, we got to loosen the hammies, and number two, we got to start, like, we have to have belly, we have to have the butt so that we can twerk. That's how strong our butts have to be. That's a good
analogy. I'm going to use that. Butts so that we can twerk. Yeah, I love that.
Yeah, because that's the root cause. Sciatica, so many things that are connected to it, and it's not just the
Yeah,
lumbar.
yeah. So it's that transition
Mm-hmm.
from spine, sacrum, pelvis, anterior, and then we got our lower extremities. It's all connected. But
Yeah.
when we're off at all those areas, you know, we're a setup. You know, oh, I got an ankle sprain, or I got an OCD in my ankle. Oh, I got a medial meniscus tear. Oh, you know, I've got I've got a labrum tear in my hip. Oh, I've got SI joint pain. I've got a herniated disc. All these things, a lot of times, when you're building them back, you're building their alignment. That's the first thing you're looking at. You can't build them in malalignment because they're just gonna never get better.
Yeah. 100%. Because I have had patients and I have worked with seniors before that if it's just an ACL tear, they will just strengthen the quadriceps. That too, if it's just the right knee, they're just working on right knee. It's been 4 months, you're just working on VMOs and quadriceps just for the right knee. That leg looks so much stronger and bulkier, and the other leg looks like a chicken leg.
Yeah,
So it's like both. You have to work on both the knees, you have to work on both the hips because they are connected to your hips, they are connected to your glutes. That's a like when you're squatting, that's why I love squatting. I love putting every patient on squats because it's a beautiful lumbar, hip, knee, ankle workout.
absolutely. Oh, it's a great. It engages all the muscles. That's a great workout.
Mm-hmm. Yes, 100%. You're also specialize. You also specialize in sports surgeries. What are a few sports injuries that you come across?
I do a lot of shoulder surgery. I do a lot of arthroscopic work. I do rotator cuffs. I do labrums, biceps. Mainly I'm a mainly arthroscopic practice. I do in some instances, if I have to do a total shoulder, I do like a resurfacing step total shoulder. Those do phenomenal. I'm a big fan of that technology. So I do everything in the shoulder, and as far as the knee goes, I do complex ligaments, ACL, PCLs. I do multiple ligaments. I do meniscus repairs. I do cartilage transplants. I do inlay resurfacing, which is for the older patient over 40 when a cartilage transplant isn't indicated, but they've got a good joint. I'll put a metal inlay resurfacing in there. I do inlays and combos, meniscus transplants, cartilage transplants. I do everything except total knees. I don't do partial knees because in sports medicine we're really. I mean, I did a few, but I kind of stay away from that because we're so specialized in orthopedics that the people that are better at that are the people that do adult reconstruction fellowships. I did a sports medicine fellowship, so my preference is to stay in my wheelhouse and not wander from it. My dad taught me that. He was an orthopedic surgeon, and he always said, just stick to what your fellowship was, and that was really good advice because it pays off. It's a lot easier. It's better for the patients. When you have a total knee or something like that, you just refer it to a guy who does total knees, just like he refers you to the shoulders. And if it's that way, then the patients are going to get the best care, and that's really what it's about.
Yeah.
So that's been my philosophy.
So your legacy.
Yeah, yeah. My father was an orthopedic surgeon,
Yeah.
and wow, what a story. He did the first total hip in the United States. He was a pioneer. He was an unbelievable guy, very competitive guy. I learned a lot.
Really? He did the
Oh, this guy was competitive. He was just brilliant. He learned the procedure at a meeting in Montreal, Canada, from the guy who invented total hips in England. The guy's name was Sir John Charnley,
Right.
and they didn't have any of the equipment. So he went to the meeting. He bought the equipment with his own money. Back it was 1967. Back then, he bought the equipment with his own money. The cement did not exist here in the United States. He actually had the cement smuggled from Canada. His sister in Montreal, who was an ophthalmologist, sent the cement, and he bought all this equipment. It was his own equipment, and out here in the suburbs at Edward Hospital, the first total hip in the United States was a Benedictine monk from St. Procopius Abbey, and it was a Ferrar prosthesis. It was metal on metal, and he did it, and he had 50 under his belt before one of his professors at Northwestern. We both trained at Northwestern here in Chicago. Northwestern was one of the, top, it still is, orthopedic departments. Back then, the American Academy was founded at Northwestern, but Clinton Compier borrowed my dad's equipment to do his first total hip in 1970. My dad had 50 under his belt before Clinton Compier did the first one, and Clinton Compier wrote up, I think, one of the first write-ups. My dad wasn't one of those, academic guys who published things. He just did stuff, and he was a phenomenal surgeon. He was unbelievable. I was very fortunate to have a mentor like him. Obviously his impact, brought me to this phenomenal field. But I'm totally indebted to the values that he bestowed upon me,
Yeah, I always ask everyone, how did you get into medicine and what made you choose your path? And this is so interesting. Tell me a little bit more about how he inspired you and, about his techniques, how he himself got into medicine.
Well, he was. I'm. My background. I was born here. My dad wasn't. My dad was. I'm Armenian. My ancestry is Armenian, and I'm Russian and Ukrainian, but on my mom's side. But my dad's side, I'm Armenian. But he grew up in Iran, which is he was a Christian, but he was a Christian in a Muslim country, and he was a very good student, but he was an unbelievable soccer player. He was when he was 17 years old, he was recruited to be on the national team for Iran, and he was a captain of the national team, and he played soccer throughout medical school, and he was their goal scorer. He was the most important player on their team. There were times I heard stories when he wanted to study for a test in medical school, and he told the team he wouldn't go, and the Shah of Iran would pull him out of medical school so he could study and train in Shah's palace. And that was like my dad. It's like, so he could have played for Manchester United. He was like that level, but he wanted to be a doctor. He wanted to come to the United States. So he made a decision, after, playing all these internationals, after scoring goals, and being a country, he was a national hero. After all of that, he came to the United States. He didn't speak any English, and he went to medical school, and then got training, got an internship at Cook County, and then went to Northwestern. And at Cook County, they were making fun of him because he couldn't speak English. So he had to learn medicine and English at the same time.
Wow.
And he did. And then I think that adversity in the beginning, where they were making fun of him and, making fun of his accent, and he ended up becoming like the best resident. Like he was like better than anyone. He was at Cook County Hospital here in Chicago during the Vietnam War, and he was like in charge of like 4 services, and he became like an unbelievable surgeon. That training ground, forged it. But I think the fact that they were making fun of him, and he was competitive by nature, and he always, had a strong heart. um, drove him, and it drove him to amazing heights. So I think that combination of, coming from another country, coming to the best country in the world with all the opportunities, and, just, not, not letting little things get, mentally being tough, and just kind of overcoming all that. I mean, that was, who couldn't be inspired by that? It's an incredible story.
Yeah. Sounds like, you need to make Grey's Anatomy out of it.
Oh, it's yeah, unbelievable story. I mean, that's what this country's about, though. There's so many stories like that where people come over and do great things. He did great things over there, but he always knew that. And he would have easily been a pro soccer player, but that's not what he wanted to do. He knew that was a stepping stone, and he wanted to do orthopedics. He wanted to do medicine, and he trained with some great people, and and he reached great heights. I mean, not only first person to do total hip, he was one of the first people to do arthroscopy, which is what I do, sport. Yeah, he learned from Lanny Johnson, so he was always learning cutting edge stuff. And it was funny because he was always fighting with the administrator of the hospital, like, we need this equipment. No, we don't. So he would buy it and say, screw you, I'm doing these cases. This is what we need to do.
Yeah.
Just incredible. So, yeah, I was blessed to have that over my roof. While I was growing up, I was really, really blessed.
Yeah. Cutting edge is everything. If you don't accept it, like social media, how much ever I suck at technology, I'm not even going to deny it. But it's the new thing to go. Telehealth is coming up, and we have to go with it. Social media is coming up. We have to use it to do good instead of wasting that technology, wasting that advancement. So I 100% like agree with like the cutting edge technology and accepting it.
Absolutely. Oh, I mean, social media is key right now. I mean, I use Instagram for my patients, for patient education, just to chronicle the journeys. Because you know what? Who's going to tell? Like today, I'm explaining surgery to people, and then at the end of it, and the thing I go, here's my Instagram. Here's the people that this person had what you had. Um, worst case scenario, this is the other person, and there's nothing like it. I mean, they're going to relate more to someone else's journey than. I mean, it's important that we talk to them about the what we're going to do and all that, but at the end of the day, they want to see the journey, and yeah, this is a very powerful medium, and I think it's really important that we use it, to the ability to try to answer questions, and just try to help people out the best we can. You're right; it's very powerful.
Yeah. Why sports medicine?
Wow. I I I mean, I was kind of in sports myself. I played soccer competitively. I played baseball, and I like arthroscopy. I like doing things through the scope. I like the minimal incision. I like the idea of going in there using small instruments, repairing structures, and then getting people back to sports, back
Mm-hmm.
to work, back to their lives. So, it's interesting when I was working with some of the pro sports teams earlier in my career. That was like only a couple percent of my population. Most of my patients were normal people that were either playing sports or actually hurt themselves. And those structures are commonly injured, when it comes to the knee and shoulder. And when we talk about sports medicine in the United States, it's arthroscopy of mainly the knees and shoulders, some ankle and some elbow, but it's mainly knees and shoulders. That's what a sports medicine fellowship is. I really like those structures. I love the anatomy,
Yeah.
and I like doing things, arthroscopically.
Yeah. Be honest and tell me how effective corticosteroid injections are. Because the first one, the feedback that I get is from my patients, the first one works miracles, but the next two are not so effective. So I keep wondering, what's the mechanism and why are we still doing it and pushing towards that?
You want to know my opinion on corticosteroids? I
Yes.
hate them.
Yes. Thank God. Finally.
I hate them. Okay. Now, I have to do them in certain patients, unfortunately, here in Illinois. I take care of some workers' comp patients, and they require us to
Yes.
do corticosteroid injections in the shoulder, in 100% of the shoulders, and it's horrible. Corticosteroids, literature shows, damages tendons, okay, long term, okay, and it's only temporary. They only get temporary relief when you're dealing with things above. And a good way to think about shoulder pathology, the watershed age is like 40. Under 40, you're more likely going to have glenohumeral problems, labrum, biceps, cartilage, instability. When and this is just a general rule of thumb. You know, there's standard deviations that can exceed this on either side of that spectrum, but it's a good rule of thumb to think of the shoulder. 40 and above, you're now more rotator cuff, bursa, AC joint, biceps also, because the biceps seems to go both ways. But when we're dealing with that 40 plus patient, they've got a partial thickness rotator cuff tear, and you know, workers comp, I've got to do a injection. Anyone else, I don't do it because it's only going to make them worse. So I'm either going to treat them with therapy or I'm going to go to surgery. Now, as far as injections go, I don't like corticosteroids because they will damage cartilage. Okay, that's been shown in the literature in the knee. Okay, so I cringe when they say I have to do an injection in the knee. I
Right.
almost want to refuse 99% of the time. In the shoulder, I don't like doing it because it's also bad for the tendon, although we routinely do it, but the literature is very clear about this.
Right.
So there are alternative injections that we can do that can help the shoulder, the rotator cuff. When we're talking about that, we could look at plasma-rich platelets, platelet-rich
Yeah.
plasma. I'm sorry, PRP
Yes.
injections, uh, leukocyte-poor injections seem to do okay with tendinosis, but not in terms of regeneration. The only thing that we see right now for regeneration of partial thickness rotator cuff tears, because the problem is on a microscopic level when you're looking at these rim rat tears, is that there's mast cells that are chewing away at that tendon. And the recent Japanese data, Japanese study shows that in 1 year, 30% will go on to full thickness tears in the Japanese study, and 50% will progress in that year to worsen that partial thickness tear. So, and the problem on that microscopic level is the mast cells, and there's no real solution to that except surgery or possibly fat stem cells. Fat stem cells in some studies now are showing regenerative properties, but it's too early to tell right now. The only problem is to get those fat stem cells, it's got to be in an operating room setting. So I'm not a fan of steroid injections. I hate them. I only do them because I have to in certain workers' comp patients. But if you're a normal commercial payer, come in, I won't do it unless the patient asks me, and then I'll tell them, there's problems, or uh, um, in other cases, I don't do them. I don't like steroids.
Thank you for that honest answer. And the yeah, because I keep wondering, and now
It's
it makes sense.
it's so outdated thinking.
Yeah.
It's so 1990s. Okay, we have so much data to show the contrary. We shouldn't be doing it. Okay, we shouldn't be doing it yet. It's amazing. Like we get these IME reports in workers' comp, and they say corticosteroid injection. I'm like, oh God. And some of these people know better. They just freaking know. They're smart
Yeah.
guys, and they're making recommendation, and they just know better. So yeah, the answer.
I doubt that. I doubt that. You know that we have 70 to 80%. I myself have workers' comp. 70 to 80% of my patients are workers'
Oh
comp.
wow.
And we had one patient come in and he says that he had an extra bone growth. So because his body keeps producing a lot of calcium, so he had an extra bone growth after a knee surgery. So it's a very interesting case, and the doctor recommended to go for physical therapy and get the bone removed.
Wow.
Yes. So he comes in and he's like, the doctor asked me to come for PT and get the bone removed. I'm like, you're expecting wrong. This is not what physical therapy is all about. I did one-on-one patient education, and I explained to him everything about what to expect, what we do, and how we'll go ahead. And this is the workers' comp doctor, not his primary care physician. So I told him, like, why don't you? I connected him with other patients because now it's like a community. We have set of lawyers, we have set of doctors that we are one-on-one with, and we connected him with a few lawyers, and the lawyer told him to go keep the camera of his phone on and tell that doctor, hey, I'm recording whatever is going on in this examination. So
Good for you.
he went in, he said that, and the doctor almost shit himself because he could not fake anything after that. He could not write anything false about it. And then he had to like write down everything. Oh yeah, that's not what you expect in physical therapy. He approved him for physical therapy before surgery. And after 2 to 3 months, he did get his knee surgery, and they removed a lot of like debris and a lot of the plaques around the knee. And he got a surgery, and then when he came back, because we were doing so much intense PT before, the recovery was very fast and very good.
Wow, that's great. That's
So
treat a lot of workers' comp patients. They're tough cases, and they really good care. I mean, it's really, to get people back to work. That's a big deal. You know.
especially when they come in with number one, their stories are so incredible in the sense like how they injured themselves, and it's never one body part. So you have to be so cautious and so considerate about body as a whole. That's how even I start looking at patients' body as a
You
whole.
know what? But I got you want an interesting workers' comp story about cortisone injections in the shoulder?
Yes.
You want to hear one?
Yes.
Okay. Do you have time? Okay.
Always.
There was a patient that I saw as a second opinion. She was a worker, Hispanic patient, and they kept giving her. She had they diagnosed her as a partial thickness, and I looked at her MRIs. I looked at all her MRIs.
Right.
So they initially diagnosed. She came in. She hurt her shoulder. I think it was her right shoulder, and she had a partial thickness rotator cuff tear. She would go to the occupational health clinic. They would give her an injection so she could go back to work. She'd go back to work. She'd work for a while, right? And then the pain came back. It was really unbearable. She couldn't go back to work at that same work status. So they did another injection so she could go back. They kept doing injections in her shoulder. So after the third, and this kept happening for like 3 times. After the third time, she said, listen, I can't take this anymore. I'm changing my doctor. She got a second opinion. She went to an orthopedic surgeon. He did a new MRI. Guess what it showed? Full thickness rotator cuff tear. It had progressed. What do you expect? She had 3 injections and she was working through the pain. So you have a partial tear, and this is coincident with the Japanese data. These do progress. The partial tears progress. 30% go on to full, but it doesn't help by doing these
And go
injections. You know,
back to
so
work.
so they kept doing and then sending her back to work because they wanted her to go back to work. And they kept doing this to her. Now she sees me for a second opinion. She has a full thickness tear. We're waiting to fix her rotator cuff. It's their fault. They should have treated this in the beginning. Now she's waiting for approval. It's unbelievable. I mean, it's a nightmare. And it's been like, what, 2 years? So that's your corticosteroid story right there.
Yeah. These, number one, they make the patients wait for years.
It's bad. It's bad in our state too. I mean, we gotten a little better. They're now starting to approve these. I get approvals. They see my name, my reputation, everything, and that helps. But you're right. Years, it's horrible.
Yeah.
What are you thinking? What does it do to the system? What does it do to the patient? What does it do to the family? What does it do to society? Like, you're 2 years waiting. It's horrible.
And I mean, like, I understand the case. It's something that's legal. That's where we cannot overstep
No.
also. But that can be, the decision any which ways is made much later. As soon as they know that the doctor has approved for surgery, they should just allow it. The workers' comp system is a little flawed,
Yeah.
definitely.
No, it's too slow, and you're right. I think the people that get hurt, if you think of in Illinois, a lot of our workers are Hispanic. And they're falling in the cracks. They don't speak the language, and the laws, are tough, and they're, some of them are worried about making noise because maybe their status, all that, and these companies are taking advantage of these people. It's really not correct. They're working, they're trying to make a living, they're helping their family, their community, and they got hurt at work. What are you going to do? So yeah, it's really, you're right. It's really tough.
Yeah. Where I work in Queens, New York, 90% of my patients are Hispanic too, and they are few of the hardest working people.
Very hard working. They want to go back.
Yeah.
They're really fun to take care of because they really want to get back.
Yeah.
I had a lady, workers' comp lady. She had 2 knees approved for surgery, okay? And her family depended on her. She was the breadwinner for her kids and everything.
Yeah.
And we explained to her, that both got approved. What do you want to do? Like, this was right before surgery. I go, do you want to do one and stage it? I let the patient decide. She said, I want to do both, get it over with so I can go back to work.
Yeah.
I mean, that's just, I mean, that, when you see that, that's inspiring, I mean, it's like, a lot of my patients are heroes,
Yeah. Yeah, I know. They're so sweet and kind. Like, them, Hispanic community just in general, they're
Amazing.
just,
Amazing.
family oriented. They just want to be left alone. They want to work and earn their money. Just very simple people. I love them. Plus, they always mistake me to be Hispanic. Sometimes they do get offended when I cannot speak in Spanish. And then they'll ask me, like, where are you from? And I'll tell them I'm from India. They're like, no, stop it. Stop, screwing with us. I'm like, no, really. Yeah, but yeah, they're very sweet.
You're gonna have to learn Spanish.
I know.
It's easy. It's easy.
Poquito.
Poquito.
Yeah,
Poquito
poquito.
dolor, rodilla, hombro.
Yeah.
You got
I know the body. I can get through an evaluation.
That's fantastic.
Yeah. For me, that's a job well done. If I can get through an evaluation, a few curse words here and there just to know.
Of course. Just great guys.
To have my basics ready, or at least if someone is cursing me, I should know about it. I want to know.
Absolutely.
Yeah, 100%. But that's amazing story, because if it was just a partial thickness tear, and if they did the therapy the right way, I don't think, even I have seen cases where they don't need to go to surgery.
Yeah.
That's why they prescribe therapy, and they push for therapy so much.
You got to do therapy initially, but when they fail the therapy, then you're wondering if those mast cells are still there, like the Japanese have showed. It's the Rembrandt tear. And these things progress. 30% go on to full, and 50% get worse. But yeah, always therapy first. Therapy is the first line. We don't operate until you've had at least 12, 15, 20 visits of therapy, you know? And then if it's still, you know, then, you know, maybe something, some biceps, a cuff, AC, you know,
Yeah.
then it's tough because you got all those pain generators going on. But yeah, therapy is the hallmark. It's the hallmark.
Yeah, definitely. How do you approach patients? Like, what do you think patient-doctor relationship is or should be?
Well, uh, the patients are number one. They're my boss,
I
you
love
know,
it.
and they're my best teacher. They're my professors also.
Yeah,
So you know, they're the ones that keep me employed. You know, they're the ones that provide for my family.
yeah,
Um, they also teach me. They're my best professors. I learned more from my patients than I did from anyone that taught me surgery. You know, because you know, basically what we do is surgery. You know, we make our adjustments as our career matures. You know, we're able to see certain things on physical exam. The history is really important. That's the most important thing. The patients give us the answer if we take a good history. The physical exam confirms it. The third most important thing, third, is the MRI. MRI is not first.
yeah.
It's third. Third. It's the patient, the patient, the patient. The history's first, the exam confirms it. And then the MRI is like a secondary thing, you know. But it's not the MRI. You know, so many doctors go right to the MRI. Oh my God, big mistake. The MRI is after you do all the other stuff.
Here in New York, because of the population, because of so many cases, I have had patients come up to me and say, like, I went to my PCP and they did not even greet me. They didn't even have time to say hi, hello, how was your day, or just greet. They just took a look at my X-rays, my MRIs, and they were like, okay, so this is what you need. We're going to approve you for more physical therapy, or we're gonna try another set of scans or something like that. So it's really sad to see that, and trust me, I have got so many misdiagnoses
Ah,
where they say it's carpal tunnel, but it turns out to be something to do with the elbow. It could be tennis elbow, golfer's elbow, but they just write the wrist pain because the patient has difficulty, moving the wrist. And I have got so many cases where it's not what it's supposed to be. Because I also have experience from India and I have worked with the doctors there. I was so glad to work with like the doctors one-on-one, orthopedics in the ICUs, critical cases, and that's the best practice because you know what the surgeon is expecting from you as a therapist, and you can give, you can let them know of what your progress with the patient is. But I have seen, especially I'm talking about New York, that the practice is a little less than what it should be. There is more expectations from the patients, also from everyone. It's we're medicine. If we don't understand pain, who else is going to understand their pain? So it's sad to see that that quality of care going downwards.
yeah, yeah, no, it just yeah, it's tough. Yeah, you, yeah, I'm fortunate. I got the type of practice where I can practice, you know, without having pressure to see a lot of patients, and
Yeah.
you know, I mean, we do see a lot of patients, but it's not like you know, crazy, you know, where you're high by, you know, you have to do the history. You got to know your patients. You got to get to know them, and super important. So yeah, if you don't do that, you're right. It's it go you'll miss things for sure.
That's why when I started this practice, I was so fortunate that my employer, also the CEO of our company, she's a physical therapist herself, and she gave me the opportunity to do things like have my own, like practice it the way I wanted to. And in India, like 1 hour is not, I am very talkative. I love talking, that hence let's talk about health, the talk show. But I love talking and knowing what's going on personally. So I will have patients come in, and they will not just sit for 1 hour. They will sit, they make friends. It's like a community now. They will make friends with other patients. They can connect, especially workers' comp patients. They get to discuss those things. And like you said, people like to know the journey, that someone else is in the same boat, and that's comforting. That gives them a lot of comfort. Also, a lot of pain comes from stress. It's stress triggered. So when you talk to them, you're taking away a part of their stress.
Right.
So it's taking away their pain. So
No, you're right. You're right.
definitely. What is one piece of advice that you would like to give 18-year-old self?
18-year-old me?
Yeah.
Piece of advice. Oh, that. Uh, what piece of advice? 18. Wow, that's a great question. Don't get sidetracked with sports. Because when I was 18, I was like, I thought I was going to be pro soccer players. you know,
Yeah.
no, yeah,
But knowing sports helped you be a better sports medicine
yeah.
doctor.
Right. You're right. You're right.
So
You're
you
right.
are perfect.
I think all sports medicine doctors are frustrated athletes. You know, they're all like guys that got frustrated with sports, I guess. So
Trust me, the sports medicine therapist also.
yeah, there you go. Right.
Yeah. But I love the fact that you were perfect the way you were at 18. There's no advice to be
Yeah.
given.
There's no advice.
There's no
Right.
advice.
Exactly.
What is one piece of advice that you would like to give the audience who is listening out there?
Um, have really high expectations of your doc. Make sure they take a careful history and listen to you, because you have a lot to say, and you're the one that's going to tell them what's wrong with you. So if they're not listening to you, and they don't want to listen to you, find a doctor that will listen to you, because that's the one that's going to help you.
Definitely. That was wise. Thank you so much. Thank you for taking the time out and speaking with me today for Let's Talk About Health by Bhavna. It was such a pleasure. You were so honest, and thank you for all the knowledge. I'm so glad that we could do this today.
Yeah, absolutely.
Yeah.
Thank you.
Thank you. Have a lovely night. I hope you get some rest and lots of food.
Okay, there you go.
Bye-bye. Take care.
Bye.